Hello, my name is Seth from the Center for Thyroid and Parathyroid Surgery. In this video, we will be discussing a central neck dissection. A central neck dissection is a surgery that's performed to remove the lymph nodes in the central neck compartment because there is concern or confirmed spread of the thyroid cancer to these lymph nodes. This is usually performed at the time of your initial thyroid cancer surgery, or sometimes if there's signs of cancer recurrence in the future, and it's performed on its own. The central neck compartment starts at the hyoid bone in the neck, going all the way down to the top of your sternum or chest plate between the trachea, your windpipe, and the carotid artery. There are right and left central neck compartments. Based on the location of your cancer, you may need one side or both sides, which we call bilateral central neck dissections. Now, anytime you are performing a neck dissection to remove lymph nodes with cancer, we do not just berry pick abnormal appearing lymph nodes. If you were to do that, there's a high chance you would leave cancer behind. Instead, we perform what's called a comprehensive central neck dissection. The analogy is, instead of going into a tree and searching for these berries, instead you strip every branch and twig of all the leaves and berries to ensure that you haven't left any berry or cancerous lymph node behind. This surgery, a central neck dissection, is performed under general anesthesia in the operating room. Again, either part of your initial thyroid cancer surgery, or potentially if the thyroid cancer has come back down the line. For general anesthesia, you have an IV, and medicine goes to the IV, and you go completely asleep. Once you're asleep, put a breathing tube down your windpipe to breathe for you. I use a special type of breathing tube that allows me to monitor the nerves to your vocal cords, and I'll explain why that's important in a little bit. I make an incision low in your neck through a natural horizontal crease, the same incision we would use to perform the thyroidectomy at the time of the surgery. It doesn't have to be any bigger. Or we would use the previous incision that was used for the initial thyroid surgery if this is a cancer recurrence. To perform a one-sided central neck dissection, it takes about 30 minutes. Bilateral can take up to 45 minutes to an hour. Once I'm finished with the surgery, I close the incision with a few stitches that go beneath the skin, which will dissolve on their own. On top would be blue skin glue and white bandages embedded in the skin glue. The nice thing about this type of bandage is you can get it wet. So that night or the next day, you can take a shower, you just let soap and water run over the bandage, no scrubbing, pat it gently and dry out the towel. This bandage stays in place for 2 weeks. If it's on any longer, you peel it off. So very simple and easy to take care of. Now, sometimes the bandage falls off before 2 weeks, not a big deal, you just leave it be. Once the bandage is off completely, you will notice a few bumps along the incision line. Those are the deep stitches that haven't dissolved yet. I promise you with time, those bumps will go away. And once the bandage is off completely, you can scrub the area like normal. Now, before you wake up, we take the breathing tube out, watch you in the recovery area for a couple of hours. As long as your pain is controlled, you're eating and drinking okay, you should be able to go home the same day. So it can be an outpatient surgery. Now, if you're older, have any significant health problems, experiencing lots of pain or nausea in the recovery area, or you live farther than an hour away, we would have a low threshold to watch you overnight in the hospital and discharge you the next day. I call you the next day. If you went home the same day, I call you the next day and check in on you, answering questions you might have. And I call you in 2 to 3 business days when I get the pathology report back. Now, with thyroid cancer, typically this gives us one of the first pieces of information we would use to determine if you need any additional treatment following your surgery, namely the form of a radioactive iodine pill. You come back to the office 6 weeks later to make sure everything is healing okay. A few days before, we will ask you to get some blood work done just before that 6-week appointment. One of the most important things we're going to be measuring with that blood work is your thyroglobulin level. That's the tumor marker level in blood that indicates how successful we were in removing all your thyroid cancer from your body, and also is the second piece of information we use to determine if you need that radioactive iodine treatment. Recovery from this surgery is about 5 to 7 days. During that time, you will have pain and swelling around the incision, as well as a sore throat when you swallow and a hoarse voice when you speak. Typically, that pain can be controlled adequately with between alternating with Tylenol and ibuprofen, as well as ice packs and sore throat lozenges. I do send you home with a few low-dose narcotic tablets just in case you need something extra. If you do, it usually is just the first night, maybe into the next morning. I also send you home with an anti-nausea medication. This is a tablet that dissolves underneath the tongue. Sometimes a general anesthesia can cause nausea and vomiting, and I don't want you throwing up after the surgery. A, because it's a miserable experience, and B, it increases the risk for bleeding inside the neck. So if you have any signs of nausea, please have a low threshold to take that anti-nausea medication. Otherwise, you just save it for a rainy day. Also, because we're going to be, well, depending on if your surgery was both-sided or if you had a history of a thyroidectomy in the past, I will be asking you to pick up over-the-counter calcium supplements because the parathyroid glands during the surgery could have been accidentally removed or manipulated, and that increases your risk of having low calcium levels afterwards. These calcium supplements are found over the counter. A normal calcium supplement usually is like a large horse pill, and it hurts to swallow or you have a sore throat. So I do encourage you to pick up a chewable calcium supplement, either in the gummy form or a tablet. For example, Tums is a nice chewable tablet. I do ask you to start that medication, the calcium supplement, on the day of surgery and continue for a 3-week period. I do ask you to look for signs and symptoms of low calcium, which include numbness and tingling in your lips and fingertips, or cramp in your hands or feet. If anything like that is going on, please call the office right away. It means your calcium levels are low and we need to change up the regimen of calcium you're taking. I send the 2 prescriptions electronically to your pharmacy that's on file, and you can pick those up on the way home from surgery. I do ask that you take it easy for 1 week, avoiding any strenuous activities that would elevate your heart rate or blood pressure and increase the risk for bleeding inside the womb. It means no running, no jumping, no lifting heavier than 10 pounds for 1 week. After 1 week, there are no restrictions. We can do whatever you like. Throughout the entire recovery process, there's no restrictions with the positioning of your head and neck. You can sleep and relax in whatever position is comfortable for you. I mentioned that hoarse voice you're going to have afterwards, but there's no speaking restrictions. The sore throat I mentioned, for that reason, I do recommend you start off with the liquids and soft foods. You can go to solid foods as soon as you tolerate. That may take 1 to 3 days. You can drive once you're off the strong pain medication, and once you can turn your head and neck to check your blind spots without hesitating. That's also about 1 to 3 days. So essentially, I'm asking you to take it easy for a week. You can do things around the house, just nothing that gets your heart rate or blood pressure up. You can go up and down stairs slowly and carefully. You can go run errands when it's safe for you to drive. And typically, I'm recommending a week off of work, maybe 2 if you're doing manual labor, lots of heavy lifting. So that's the surgery, and that's what the recovery is like. Next are the risks. One of the major risks here is risk of cancer recurrence. If the cancer were to come back in the future, you may need further treatment in the form of surgery to try to cure it. Very rarely does the cancer come back and turn into something that can be very aggressive or life-threatening. Next are risk to injuries on nearby structures in the neck. The most important one is the recurrent laryngeal nerve. This is a nerve that controls the movement of your vocal cords. It's very important to find this nerve and completely dissect it out during this surgery, part of stripping all those branches and twigs of the leaves and berries. While that nerve is being dissected, sometimes it can be stretched or over manipulated, and it can result in a temporary weak or hoarse voice that can last several days, sometimes up to 9 months. Thankfully, this risk is low, 5% for temporary weak and hoarse voice. There is a 1% chance that nerve can be severely injured and never recovered. In that case, it could result in a permanently weak and hoarse voice. Now, pretty rare for this, 1% of the time. If it did happen, there is a second surgery that could be done at a later date in time to help bring the voice back to pretty close to normal. Conversational voice would be the same, but singing and yelling would always be off just a little bit. It's not the end of the world if that were to happen, but certainly a major inconvenience to go through that process to get your voice back. Now, if we do operate on both sides, do bilateral, both-sided central neck compartments, or dissections, I should say, there's a risk that both nerves could be injured. In that situation, that could result in difficulty breathing and potentially the need for a tracheotomy tube in your neck to help you breathe. That tracheotomy tube may be temporary or sometimes permanent. Now, I don't want you to have a tracheotomy tube under any circumstance. If you think back to the beginning of the surgery, that breathing tube I use is a specialized one that allows me to monitor these nerves to the vocal cords during the surgery. Now, if I ever needed to switch sides, if I had to do bilateral central neck dissections, once I finish on the first side, I stimulate that nerve to ensure that it's working. As long as it stimulates appropriately, it's safe to proceed to the other side. Now, if it doesn't stimulate, I would opt to stop the surgery right there, close the incision, wake you up, and we would wait for that nerve to recover before bringing you back for a second stage surgery. While a two-stage surgery is not ideal, it's much better than putting you at risk of a tracheotomy tube. Now, if your surgery is for cancer recurrence, where you've already had part of your thyroid removed and you've been operated in that area, the risk of injuring your nerves is roughly doubled. 10% for a temporary weak and hoarse voice, 2% for it being permanent because of the scar tissue and inflammation that has formed as a result of a previous surgery. Next are the risks to structures in the central neck compartment called the parathyroid glands. There are 4 of these, 2 on each side of the central neck compartment, and they're very small, like the size of a rice grain. They help to control calcium levels in the body, which is very, very important. Now, during an initial surgery, central neck dissection with thyroidectomy, it's much easier to find these parathyroid glands and try to preserve them. With revision surgery, that's a little bit more difficult to find, and sometimes they may have been removed or injured during the initial surgery. If all 4 parathyroid glands are accidentally removed because they're so tiny, or injured because they're so delicate after being manipulated, they can lose their function. If all 4 are injured or removed, that could result in permanently low calcium levels. You'd have to be on calcium supplements every day for the rest of your life, sometimes 2 to 3 times a day. If this central neck compartment is central neck dissection is performed at the same time as a total thyroidectomy, that risk can be as high as about 5%. There's a revision surgery. It depends on how many parathyroid glands may have been affected during the first surgery. And sometimes we know that based on the pathology report from that initial surgery, sometimes we don't. So sometimes it can be double to about 10% for permanently low calcium. Next to the risk of any surgery, that includes infection. That risk is very low, 1% or less. Signs of infection would be swelling, redness, and pain following the surgery. You do get antibiotics at the time of surgery. Don't need anything else afterwards. Next is risk of bleeding. There's a 1% chance that one of the blood vessels I have to seal off during the surgery to remove these lymph nodes could open up afterwards. That would result in bleeding inside your neck, which you would notice as swelling like a bullfrog. Sometimes that bleeding stops on its own, sometimes it does not. And I have to take you back to the operating room urgently to stop that bleeding, because sometimes it can be life-threatening. Is the reason why I ask you to take it easy for 1 week following the surgery. It takes about 7 days for those blood vessels to completely seal off. If your heart rate or blood pressure goes up before that 7-day period is finished, you have a higher risk of bleeding to happen. Next is the risk of general anesthesia. Usually that risk is quite low. I do require you get a physical, normal physical from your primary care doctor clearing you from surgery. If you see any specialist for major health problems, like a cardiologist or a pulmonologist, we may ask you to see that specialist as well to get you cleared for the surgery. Lastly is the risk of a scar. As I mentioned, I try to keep it small, hide it in a natural crease, or use your previous surgery from your original thyroidectomy surgery. Ultimately, it's up to your body and how you heal. As long as you don't have a history of keloid or a hypertrophic scar, usually these incisions heal nicely. I performed the surgery at Central Neck Hospital, and that concludes our talk on the central neck dissection. If you have any other questions on central neck dissections, thyroid cancer, or any other topics of the thyroid and parathyroid glands, please visit my website at sethkaymd.com. That is SETHKAYMD.com. Thank you very much for watching.